So cardio-oncology has really exploded over the last 10 years, and it comes from the success of modern cancer therapies. So whether that's for solid tumours or in hematology for blood cancers, where new designer drugs targeting molecular pathways are really curing or controlling these malignancies, turning them into chronic diseases, but the drugs have a range of cardiovascular toxicities. So you're out of the frying pan, but coming into the cardiology fire. But a lot of this is predictable, particularly if we know what people's baseline cardiovascular health and their risk factors are, and by understanding their risk, we can then triage who needs closer monitoring, who may even need to start cardioprotective medication up front, and then follow them through their treatment so that they can have their oncology treatment safely. And that's the real message. Rather than waiting for crises and cardiac complications to occur, we're trying to predict them. So in 2020, a group of cardiologists, hematologists and oncologists got together and we produced these baseline risk assessment proformas. And for the hematologists in the audience, these have been created for patients receiving anthracycline chemotherapy, particularly for lymphomas and leukemias. Also multiple myeloma therapies, particularly the proteasomal inhibitors that can cause cardiovascular disease, and for their patients with chronic myeloid leukemia who are going to be receiving second or third generation BCR-ABL tyrosine kinase inhibitors, which again, very effective drugs, but have a different fingerprint of cardiovascular toxicities. So if you understand what the problem is, we can triage who needs monitoring. And those risk assessment proformas literally allow hematologists and oncologists to grade their patients into a low, a medium or a high risk group. And it's about communication. So hematologists need to find who are the local cardiologists with an interest in this field. More and more cardio-oncology services are being set up, particularly in the larger tertiary hospitals, but now with links into district general hospitals. So communication is key, because we need to understand from a cardiology perspective how important the drug is to that person's specific malignancy, and then we can help weigh up the risks and balances of what to do in order to minimize the toxicities.